Hello, I'm Patrick. I'm a respiratory therapist here at the hospital, and most of you will know who I am. Today we're going to do a little bit of a crash course on how to set up and use our ventilators to assist in the crisis that could be coming. First of all, when you get the ventilator out of the supply room, it'll come taken apart, and you'll have to set it up and then put in some settings before the patient is connected to the ventilator. So at this point, we'll look at the back of the machine, and we're going to look at some power cords that are back in the back. You have three. You're going to have your power cord, which you'll plug in. You'll have your oxygen tubing, which you'll plug in also into the wall. And there's two prongs, and you just line it up and push in until it clips. The air one has two prongs that are different shapes, so you cannot make a mistake, and you got to make sure that it's well fastened in the wall, that you can't pull it out like I'm showing you. So there you go, it's plugged in. We'll go back to the front of the machine. This is where you can probably edit and cut a few things out to shorten it. Anyway, so when you get the machine from our room, it'll have the ventilator circuit already attached. But for purpose of education, I'm going to take it off and I'm going to show you how to put it together. This will just take a brief second. This will be important when it is time to troubleshoot and if something's wrong with the circuit. So first of all, you have an exhalation filter, which will be installed right here. You slowly insert it, facing forward with the tubing, and push this blue lever down. You want to make sure that this port is covered with this little rubber cap. You're going to take your circuit, which could be in a bag, and it sometimes has a clear tubing attached. The clear tubing is not necessary. You would just have this blue tubing. We need to plug one here for the exhalation, and we need to plug one of the tubings here for the inhalation. It does not really matter which one you use, but for ease of purpose, since this inspiratory port is indented, I'm going to use a straight one. Then I'm going to plug in the other one into the exhalation port. If we can zoom in a little closer right here, you'll see that there is a port that is plugged. We have to make sure that that port is plugged. If not, it is a leak, and the ventilator will not ventilate the patient. So make sure that is plugged in. If we come closer to the Y portion of the circuit, you'll see there's also two other ports that could be plugged and unplugged. We have to make sure that these two ports are plugged in. Like that. I'm going to attach this quickly. Have something to hold the circuit. All right. Now that you have the ventilator all connected, you want to make sure that you do not turn it on till you unplug this cap. This comes with the circuit. Even if the ventilator circuit is already on the ventilator, you want to take this off before you turn the ventilator on. If we look at the front of the ventilator, the on-off switch is right here. You'll lift this little plexiglass window and make sure it's unplugged again and turn the ventilator on. Notice all these lights in all these locations are working. Those are important because those are your alarms and your notifications if there's any problems with the ventilator. This is the initial first screen that you will see when you start. It'll say ventilator startup in progress. And then down at the bottom of the screen, you'll see a notification box here on the right. And on the left, you'll see a same patient, new patient, and SST. SST is just a test that the respiratory therapist does every time we take the patient off and on the ventilator. between patients. You don't have to worry about that. The thing you have to worry about is this the same patient you've been ventilating? Have you been to CT and have come back? If that's so, you just sit same patient and continue on with the instructions. In our purpose, we're going to say this is a new patient. We're going to hit new patient. And when we go there, you'll see, notice this notification box. It says IBW 50 kilograms, 100 kilograms. This is ideal body weight. So if you look at the patient and you feel like their ideal body weight's 120 pounds, then you would look at the bottom here and you would adjust. And notice I touch the screen. It is a touch screen. I'll spin this wheel to 120 pounds. Well, it jumps from different numbers, so you choose the closest one, which in this circumstance was 121 pounds. You would hit continue. This is going to be your modes of ventilation, where you first initially set up. For in our purposes, it's always going to be invasive ventilation, meaning with a person being intubated with an ET tube. You're going to have a mode of ventilation. Notice when I hit it, there's different modes of ventilation. For initial setup with somebody that's going to be set up on the ventilator, we're always going to go with assist control, is what AC stands for. So we're going to keep that AC. And then on the other menu button, you have different ones. VC stands for volume control, is what we're going to be using. There's also pressure controlled and volume control plus, which we are not going to use. This stands for flow trigger. That is never going to change. Anytime you turn the ventilator on, that'll be the default setting. You hit continue. And this brings you to where you set the settings that the doctor will give you for the ventilator. You have several things here. You'll have your frequency, your tidal volume, your flow. This is one of the settings that the doctor will not give you, and I'll give you a average setting that we use. Flow sensitivity, that is for the patient to activate the ventilator to give a breath. That is also one that the doctor will not give you, but it's always default to this setting, which we will leave as it is. FiO2 is something the doctor will give you, and also the PEEP, which is right there. First one, to make a change to your frequency, you highlight, spin this knob, and notice we set a frequency of 20. Normal respiratory rate to start with will be anywhere from 12 to 20. Whatever the physician decides, sometimes they go up to 24. Dr. Sadat a lot of times likes to go to a respiratory rate of 24. Next one, to make the change, is the same method. Let's say we're going to use a tidal volume of 450. The normal tidal volume method of finding out what tidal volume to use with a patient will be anywhere from 6 to 8 kilograms or 68 mils per kilogram per ideal body weight. So we'll just choose 450 right now. And our max flow, this is how quickly the patient can take a breath. The machine limits. Oh, wait a second. Oh, okay. So the max flow, we're just going to, like I said earlier, we're just going to give you a flat number, anywhere from 50 to 60. So for intensive purposes, this will fit most patients' need for flow as they take a breath. So we're going to go ahead and hit 50. Notice I did not hit accept. If you do, it will transfer it up here and it'll be set, and you'll have to make the changes up here, which I'll demonstrate here in a second. The next thing you want to change, let's say the doctor gave you, always typically start with 100% when you initially ventilate somebody and then wean down quickly. PEEP, let's say the doctor told us 5 of PEEP, we'll set that. And notice I hit that accept button. Notice how I brought it up. Oh no, I wasn't done setting it yet. Well, you could still make changes here. So we'll hit this one next. This one never changes, and we've already made all the other changes. This one is, we always want it in ramp. So if you look at it and you see it shows square, you want it like this, you want it in ramp. It just makes it more comfortable for the patient. So you just turn it till it gets ramp, and then you hit accept, and it accepted it. Notice at the top now it says waiting for patient connect. You could technically ventilate the patient now, but we have not set our safety backups yet. So we want to make sure we do that before we connect the patient. So if you look at the menu at the bottom, we've already selected our modes. Next we want to set is current apnea mode. The current apnea mode is a backup. If this were to fail, the ventilator goes back to these settings. In this particular instance with assist control ventilation in volume control, we're going to use the same numbers we put at the top. For instance, we're going to put it to 20 just like above. We're going to do 450 just like above. And we're going to change our flow to 50 as above. And we're going to change to a ramp. And then we go to our FiO2. This is a backup mode. We don't know what went wrong with the patient. We want to keep it at 100%. This little one down here just says 20 seconds. That's if the patient doesn't breathe for 20 seconds, the ventilator will go into apnea ventilation, which is this mode right here. So that stays at 20 seconds. Then you hit accept, and it's set. Notice that the stuff that was in red changed to black. We know it's done. Next, we go to the alarm settings. This is basically if something goes wrong, the machine will alarm and let us know that something is happening. The first column here for the alarm is peak pressure. Peak pressure is just, for instance, if something is obstructing the tubing, or the patient's coughing, or he has a mucus plug, the peak pressure alarm will go off. We don't want to overventilate a patient, because if we ventilate him more than, for instance, 40 centimeters of water, we run the risk of creating a pneumothorax by popping a lung. So this is a very important alarm. When we turn the ventilator on, it automatically defaults to 40, and that's where I would keep it. There's certain circumstances, sometimes we change that, but for our intensive purposes, 40 is a good number. The next one, next to it, is our total frequency. Normal respiratory rate is anywhere from 12 to 20. We know that our sick patients that have a fever will be breathing extra quickly, and we want to allow for that to happen. So frequently enough, our sick patients will be breathing 30 times a minute. So for intensive, of keeping it as simple as possible, we're going to set that to a respiratory rate of 40. So it allows the patient to breathe some extra breaths, but yet not to be breathing 50 times a minute where we know something is dramatically wrong. So 40 we'll set for now. The next one is our minute ventilation. Minute ventilation is just measuring how many liters per minute, or how many liters we breathe in a minute. And for keeping it simple, we're just going to go from 18 as a maximum and 3 as a minimum. And that'll be more of a kind of cookie cutter alarm settings. Next one is tidal volume. We're going to do some cookie cutter method here also. We're going to go to a maximum volume of 800 and a minimum of 300. And then we're going to do the same thing with the one next to it, which is a spontaneous alarm. If we put the ventilator into a spontaneous mode when we do weaning, we keep those the same. So at this point, if the patient breathes more than 800 milliliters per breath, then it'll alarm. And if he breathes less than 300, the vent will alarm. That way, if there's something wrong, their breaths are getting too shallow, we get some type of warning. After you've set those, you'll hit accept. Notice these are all red, the ones we've changed. When we hit accept, they'll change to black. So we know that's set. And that's essentially what we need to set up for the machine. Now that we're ready, we're going to be connecting to the patient. We usually have a little white bag hanging right here. And we're going to have these parts right here. An HME and a Ballard suction. And this also comes apart when it's in a container. And let me show you what that container looks like right here. Okay. So you'd put it together like so. There's also other supplies in the bag, including a nebulizer, a little MDI spacer to put medications in. But for initial setup, we're just going to do it simple, just like this for now. Notice that I have the Ballard. It's a T-piece. There's a suction. The suction goes into the patient's ET tube. So you can't make a mistake. If you were to put this over here, you know that would be wrong, because first of all, it doesn't fit, and also you don't suction where that is. So you know how to set it up like this. So you would extend, there we go. Then you would put this on the end of the tubing, making sure again these are still plugged. And once you have that all set, you would connect it to the patient. In my intensive purposes, I have this little test lung, which I'll show you here, but I'm going to reduce the tidal volume here because this is not a normal size lung for a human. So I'm just going to drop this volume down as low as I can. I'm going to hit accept. And as soon as you connect the patient, I want you to look at the screen. It goes immediately into ventilation. And we're going to get some alarms because this tidal volume, or minute ventilation, is going to be really low. So I'm going to adjust these alarms also. And notice I can do that after I'm connected. You can always make changes. And the peak pressure is going to be high also because this is such a small thing to ventilate. Notice your alarm at the top. Peak pressure. This is when you would look at a patient and say, okay, do they need suctioning? Is the tube dislodged? You look at the patient and then work your way up the circuit. One of the problems sometimes is also an HME that has been filled and needs to be changed. Somebody coughed up a big chunk of secretions and it's made its way into the HME and blocked it. Those are kind of things to look for. Okay? You got your alarm silence. If you were going to suction a patient, you want to pre-oxygenate them. And if you look right here, it says increase O2. You would hit that, and it gives 100% oxygen for 2 minutes. Okay. And since we're showed that, I'm just going to cancel those things. The alarm resets the alarm. And notice we're still having peak pressure. And that's because this test lung is very hard to ventilate, especially with that much volume. It's very little test lung here. And that's how you set up the ventilator for initial vent settings to put on a patient. Again, just as a recap, I'm going to hit silence here. The frequency, tidal volume, oxygen, and PEEP will be what you get from the physician for initial setup. If you have any questions, you can ask a physician or a respiratory therapist. If you can't seem to resolve what the problem is for an alarm, please disconnect the patient and bag the patient. Thank you.